Hello, how are you? This is our last seminar, the seminar number 12, that is going to be about antenatal care. The original version of this class, the presential class in real life, is going to be done by Dr. Reinaldo Channicharo. That is a Cuban doctor that works in Bagari, and he offered to help us with that seminar. But the online version will be done by me. I hope I can fulfill all the objectives that he proposed in the class. So we're going to talk about in this class the definition about antenatal care. What is the antenatal care? What is the prevention, the concept of prevention, what it means, and the types of preventions. There are different types of prevention. We're going to talk about a little of the program of antenatal care in Kenya, from the beginning of the concept of antenatal care and until how it's working now. We're going to talk about a very important thing in the history of this country, that is the Linda Mama program, the World Health Organization recommendations for the antenatal care. Sorry, because here is supposed to be an M. And at the end of the class, in the real class, we're going to make a brainstorm activity, but in the online version, of course, we won't be able to do that. So what is antenatal care? By the World Health Organization, the definition of antenatal care is the care provided by skilled health care professionals to pregnant women and adolescent girls in order to ensure the best health conditions for both mother and baby during the pregnancy. So it's all the things that we can do before the delivery in order to prevent all the different pathologies that a mother can have. And the three important components here in the antenatal care is health education and promotion, prevention, and risk identification. This is very important because we, in our antenatal care, we have to try to identify the women that have more risk or have a kind of alteration during all the controls, and we have to refer this mother to a higher level of treatment and diagnosis. In prevention, it's important, all the three types of prevention that we're going to talk about a little more, and in health education and promotion, it's important for us to teach to our patients about how is a normal pregnancy, what are normal signs in pregnancy, normal symptoms, and which other symptoms are alarm symptoms, and she needs to come, because this patient they sometimes cannot know. So here is an important thing that Dr. Reinaldo talked to me and want for me to teach you, that is the declarations of Alma-Ata. Alma-Ata is the capital city of Kazakhstan. It's this city that is in this picture. It's a very nice city. Why is important this city? Because in 1978 there was a conference there where there was a lot of different doctors from all the countries, and they made a declaration about the primary health care. They say that the most important thing in the public health, like to ensure and provide health to all the people, is to have a strong primary health care. And if you have a very good primary health care, you will have roots of a preventive focused health. And if you prevent, you avoid the problems. So it's the correct way to simplify, and you save time, you save money. So it's the most perfect way, the most beautiful way to give a good health for all the population. In that declaration, the main goal of the declaration was to provide health for all before the 2000, because before in that moment, like, there was a crisis of health, and only the people that have health was people that have money to pay that, or people that live in the cities. But people that live very far away in rural areas, or people who cannot afford because they doesn't have money, they were lost. So here in this declaration, they try to settle up a little of statements about how should the health system should be in different developing countries. So Dr. Reinaldo also wants to talk about what is a family-centered antenatal care, the importance of a family approach in the antenatal care. The antenatal care is all the care that you have to provide to the pregnant woman, but the the issues of the pregnant woman are not only of the pregnant woman, are issues of all the family. Okay, this is not only the woman and the wife and the husband, it's all the family. So all the family must be surrounding the woman and providing a good environment in order to make this gestation have a very good place to grow, have a very well-educated family about the alarm signs, about the things that are allowed and the things that are forbidden during pregnancy, in order to make this woman be the queen of the house. So if the woman is feeling bad, or if the woman have to work a lot, all the people in the family should help this woman, because the pregnant woman is not a normal woman. It's a woman that is now carrying a child. It's a lot of work, and everything is more difficult for her. And what is prevention? The definition of prevention is the action of stopping something from happening or arising. So we stop something before it occurs. That is the essence of the definition. So prevention is better than cure. This concept is very important because that is the reason why all the governments realized that they doesn't need to spend all the money in the hospitals, in treatments, in very high sophisticated machines to make good diagnosis, like magnetic resonance or computed tomography or X-ray or everything. No, you need to prevent. And if you prevent, you won't have patients with disease because you will pick it up earlier and you will prevent the disease to occur. So here we have a notice that shows us that in Kenya also the government realized that the prevention was better than treat the disease when it is already in our patients. So they decided to remove all the maternity fees services in all the country, and they decided that the antenatal care will be free for all, and that make a very big change. And that change I'm going to show you in results, because this change make the mortality, the maternal mortality, to go down. But first, before telling you about the results of the improvement of the antenatal care in Kenya, we're going to talk a little about prevention. We have three different types of prevention: the primary prevention, the secondary prevention, and the tertiary prevention. So the primary prevention is the prevention itself, P with P. Prevention before the onset of the disease. So you attack a risk factor. You attack the risk factor in order to prevent the development of a disease. Or also you can provide something that increases you a protective factor. For example, a vaccine. A vaccine, you give a vaccine for a patient, the patient develops more antibodies, and that is an increase of a protective factor. Or, for example, to say to a person that is forbidden to smoke. So you say to the patient, you cannot smoke. You attacked a risk factor and you prevent the disease, the lung cancer, for example, the pulmonary cancer. So that is primary prevention, before the onset of the disease. The secondary prevention, on the other hand, is all the things that you do in order to try to identify the disease early, before the onset of the symptoms. So you can treat it properly when the disease is beginning. All the things that you use for early detection, for example, screening exams. For example, Papa Nicolau for the cervico-uterine cancer, or for example, it can be also to check the BP in an antenatal care. So you check the BP all the time in order to find the patient that have preeclampsia before the onset of the symptoms. So you prevent the progression of the disease because you detect the disease early. And the last one is the tertiary prevention. That is the prevention that you make when the disease is established. So the disease is diagnosed and the patient have the disease, but now you treat the disease. And that treatment prevent the development of complications. So you reduce the complications. Okay? So in summary, the primary prevents the onset of the disease. The secondary try to find the disease in the beginning, so it's early detection. And the tertiary is treatment of the disease to prevent the complication of the disease. So here we have a mnemotechnic technique that can help us. P with P, primary with prevention. The secondary is S with S, secondary screening. And the tertiary, T with T, tertiary treatment. Okay? An example here is to give the folic acid for the mother. The folic acid is a protective factor that prevents the apparition of the development of neural tube malformations. And for example here, the screening, I told to you, the high BP. So the checking of the blood pressure in every antenatal care visit will prevent the development of, will detect early the disease of preeclampsia. Also, to check the proteinuria. And the third theory is when you have the diagnosis of a disease. For example, you have the diagnosis of anemia and you give a treatment to give iron in therapeutical doses, not in prophylactic doses. And that is tertiary prevention. Also, primary prevention is to give a vaccine, for example, the tetanus toxoid. So now I'm going to show you why is so important the prevention. Here we have a graphic. Okay, this is about the story of Kenya. We have a graphic. In this line, we have the percentage of antenatal care coverage in this side. And in this side, we have the mortality. Okay? So, in the year 2008, the percentage of antenatal coverage was 47%. And that is less than the half of the country. Most of this percentage of coverage was in Nairobi and in the important counties. In the counties where near to the northeast part or near to the coast, they have very lowest percentage of antenatal coverage. Okay, so in 2008, with this percentage of antenatal care coverage, we have a mortality of 488 deaths. That is the mortality rate in 2008. So the government, in that moment, say, oh, we need to increase our percentage of antenatal care coverage in order to improve our mortality. This indicator must be better. We're very bad. And they improve it. In 2014, the antenatal care coverage was 58%. So they increased a lot, but not completely. All these data are from the Kenya Demographic and Health Services. So are data from the government and are formal and believable data. So in that moment, with 58% of coverage of the antenatal care, the mortality go down to 362 deaths per 1,000. Per 100,000, sorry. So we can see that the graphic is going down. Also, I want to show you that this, if we divide by region, by the Rift Valley and the coast and the northeast, we realize that the northeast region have a 37% of coverage. And the mortality was very high. So here is the importance of prevention. 98.7% of the total maternal death in the country occur only in 15 out of 47 counties. And these 15 counties were the counties of the northeastern part and the coast, most of them in northern and coastal parts of the country. So here we have a map of Kenya that shows us all the counties, and here in Mandera, in Wajir, in Turkana, in all these counties, the mortality rate was very high because of the lack of antenatal care visits. So now we're going to talk about a little bit about the story of Kenya's antenatal care program. So what is important here? The Linda Mama program. In June 2013, the President Uhuru Kenyatta decided to remove all the hospital fees in the maternity area. So they include the antenatal care, the fees in the hospitalization of maternal deliveries, and in the postnatal care. This was a very important notice because now there will be no economical barriers to attend the antenatal care and all the health facilities, and that improves a lot the maternal mortality. But Only a little weakness that I find in this program is that they don't include ultrasound. That is a very important information that we need to know about our patients. But it's a first step that was very important for Kenya and for Kenyan population. So the Linda Mama Insurance, it's a program that was created between the Ministry of Health and the NHIF in order to provide for free all the basic things for the pregnant mother. And here we have a table that show us all the things that are included. I only leave this to you in the presentation for you to read, but I'm not going to read now. And in summary, this includes, for example, in the first visit, HB, blood group, RH, VDRL, and HIV testing. Also include in the places that are endemic for malaria, the MPS, and include the screening for TBC. Urinalysis in all the visits, in 3 visits at least, the tetanus toxoid schema for the vaccine, also intermittent preventive treatment for malaria in endemic areas, and also a mosquito net, the worming treatment, prophylaxis with iron and folate, and prevention to the transmission of mother-to-child transmission of HIV. So includes a lot of different things, also include the delivery issues and all of that, but I'm talking now about only ANC visits. Also, there was a development of a book. This booklet is very, very much important because it's the thing that guide all the health providers and also the mother in order to have a very good way of life during the pregnancy, very healthy way of life. So this brings education for the mother. Also, it's important because here you make a registration of every antenatal care visit of the vital signs, the BP, also the results of the laboratory. So this is very important book. Also, the follow-up for the mama after the delivery and for the newborn in the growing, in the curve of the growing of the baby. So it's very important. So for us, the principal message here is to encourage the mother to don't lose it, to take care of it, and bring it to all the antenatal care visits. Okay? If we can see, for example, here there are all the things that the mother must know about pregnancy. For example, eat 1 extra meal every day during pregnancy, eat plenty fruits and vegetables, drink plenty waters. For example, these are only examples, but there is a lot of instructions for the mother. Also, signs of reconsultation. For example, if the mother is very pale or have a severe headache, all the signs of alarm that the mother must know. So now we are going to check the World Health Organization recommendations for the antenatal care. This is a very important guide from the World Health Organization that is about the antenatal care. So here in this guide they talk a lot about a lot of different recommendations about nutrition, about a lot of different things, and these recommendations are based on very important evidence, very hard evidence. So all the things that this guide is saying, we need to put it together and apply here with our patients. But maybe we have to make some modifications according to the context of our patients and the economical status. What is the principal concept, very important, of this new guideline? That is recommended now to have 8 visits, 8 fundamental visits, and that is the minimum. And in the first guide, the guide from 2002, the recommendation was to have only 4. So here we know that all the antenatal care visit, as more as the patient have, is better for the patient. And also say that the first visit must be in the 12th week, the week number 12. That is the recommendation. Here, this paper, I only want to make a little comment, that is that the antenatal care program, the implementation of antenatal care or good antenatal care in any country, can improve not only the maternal mortality, also the neonatal mortality. Here is a paper that was made in Switzerland about that, and show that about the 38% of all the neonatal deaths in Kenya were attributable to a lack of checkups for pregnancy complications and antenatal care and postnatal care. So now I'm going to talk about the recommendations itself. The WHO recommendations are divided in four. The recommendation about nutritional interventions, about maternal and fetal assessment, about preventive measures, and about interventions for common physiological symptoms during pregnancy. So first, about nutritional intervention. In the booklet, we have this weight gain chart. So we have to take in every antenatal care visit the gestation in weeks and note the weight of the mother. For example, in the first visit was 80 kgs. In the second visit was 100 kgs, for example. So we can check how is the mother growing in kilograms with a curve. And it's very important because in the booklet also they give you counseling about healthy eating and keeping physically active, prevent excessive weight gain during the pregnancy, because all that things are related to diabetes, macrosomy, and a lot of different complications. And here I have a question for you. If a mother asks to you in the antenatal care visit, which is my recommendation, how many kilograms I have to go up during my pregnancy, which is the normal, which is the healthiest way of increasing my weight? So which is the recommended weight gain during the pregnancy? Please put in pause the video and try to answer. The correct answer is a total of at least 12 kilograms during the pregnancy with an average of 1 kilogram per month. Okay? If the mother before the pregnancy is in obesity or overweight, you can make the mother only to go up between 7 and 9 kgs. If the mother is malnourished, she's weighing very less, like an index below 18, you can allow the mother to win more than 12 kgs. But the normal here is 1 kg per month and a total of at least 12 kgs. If she's going more up than that, it means that we need to make an intervention, change the diet, start doing a little of exercise, etc. Another thing about nutritional intervention is the daily iron and folic acid supplementation. Why we give iron to the patient if they are not anemic? Because only to prevent anemia. Because during pregnancy, the iron deposits of the mother are being stolen by the fetus, so the mother can develop anemia. So it's very important to give iron. And the other thing is that the folic acid, 0.4 mg every day for the mother since the moment that she diagnosed the pregnancy is very good because it prevents the malformations of the neural tube. They prevent all the malformations in the spinal cord, so it's very useful. It's recommended for pregnant women to prevent maternal anemia, puerperal sepsis, low birth weight, and preterm birth. So here also in the booklet we have this table where they mark how many pills do they have to give and the date given and everything of that. So it's very important for the registration of the delivery of the drugs. Maternal and fetal assessment. This is the second part of the World Health Organization recommendations. It's very important, this part, because here we can check all in this table. This table is very important because here we can check all the things during the pregnancy, visit by visit. So we can check how is the mother increasing the weight. We can check how is the BP of the mother. If she had the high BPs from the first visit, it means that was not preeclampsia, was pre-gestational hypertension, for example. If she had normal BPs, but here in the week number 22 she started with high BPs, that means preeclampsia. For example, the HB also, to check how is the HB in the first visit, because here is the exam of the HB is for free. And then if it's less than 7, the mother can have another HB exam. We can check all the things. For example, if the mother has pallor, the fundal height to check how is growing the baby. A lot of different things that are important to check how the baby is growing. Maternal and fetal assessment have a second part that is the screening of anemia. So it's recommended for the mother to have a full blood count testing or a HB exam in the first trimester. And this is wrong. I checked it in the Lindia Mama program and they control only the HB in the first trimester, but if in the first trimester was 7, the mother can have another control of HB in the next controls, or also if the mother have any sign of anemia like pallor or tachycardia, she can have another exam of the HB again. So I have another question here. And does someone know the normal values of HB in pregnancy? So when we can diagnose anemia in pregnancy? Please think a little about it and post the video, and then I will show you the answer. So this is the answer. In the first, depends on the trimester. So in the first trimester is 11 points. In the second trimester is 10.5 because this is a physiological hemodilution, because all the plasma volume increase and the hematocrit, the amount of red blood cells also increase, but not too much in relation with the plasma increasing. So that's why there is a kind of a physiologic anemia. And in the third trimester, it turns back again to 11. So to diagnose anemia is under 11 in the first and in the third trimester, and under 10.5 in the second trimester. Another very important thing to assess during all the pregnancy is the asymptomatic bacteriuria. What does it mean? It's like a urinary tract infection, but without symptoms. So there are bacteria growing in the bladder or in the urethra, but there is no symptoms. And why it's important to detect it? Because this is related with preterm delivery, preterm labor symptoms. So we need to detect it. Which is the best method? The urine culture. This is the best method to detect the asymptomatic bacteria. But the problem is that it's expensive and it's not available in all the places. In Bagari, I thought that we don't have that, but Reinaldo told to me that we have it. And the common method that all the people use is the dipstick method because it's very cheap, very fast, and very easy to do. But the problem is that it's not very specific. What are the important concepts here? If in the dipstick method you have nitrates positive, you have a high risk of infection. So you treat it, like as a UTI. But if there is only leukocytes, only 1+, you don't treat it. But if you have 2 or more, you have to treat it because the likelihood ratio to have a urinary tract infection is high. And if you have maybe 1+, but you have symptoms, or if you don't have any change in the dipstick, but you have urinary tract infection symptoms, you have to treat it. Which are the symptoms? Dysuria, pollaquiuria, that is an increase in the frequency of the mictions, of the susu, and tenesmus, that is like feeling that you have urine in the bladder, but you go to the bathroom and you don't have anything. So you feel like you have urine in the bladder, but you really don't have. All of that are symptoms of infection. So you treat the infection. And which is the recommended treatment? Nitrofurantoin 100 milligrams BD during 5 days, 5 to 7 days. Okay? And after the 7 days, you have to repeat the urine culture or repeat the dipstick in order to rule out the resistance of the bacteria. Remember that you will never give ciprofloxacin or any floxacin to the mother because of the risk for the fetus. Another very important thing to check that all the people sometimes forget or is difficult, feel like ashamed of asking or feel like it is another important topic is the intimate partner violence. And this topic is very important because this mother in a pregnancy, sometimes it can be an unwanted pregnancy, it can be a pregnancy in an environment of violence. So we need to ask that because if we don't ask that, maybe the mother will never say to us. This mother can be very afraid. There can be young mother, teenage mothers, or raped woman. So it's very important to be very soft to ask and be very carefully, like very wise and talk very calm. But try to understand the mother and try to ask a little bit about the question, so maybe she can say something. So which things it's recommended to say? For example, ask, how are you feeling about your pregnancy? That little and simple question can be useful. Also to talk about her family, like, are you married? Or how is your relationship with your family or with your husband? And if you find some kind of psychological or physical crisis, abuse or something that you think we need extra help, you can ask Fundación Maisha. That is the foundation where me and Wenceslao work, also Dr. Reinaldo works, and here we can support this woman, most of them the young women, the primigravidas of 15 to 17 years, that are some kind of crisis. We can give them housing, we can give them food, psychological support, okay, company, like friendship. So you can talk to us. Here I have a photo of our mothers that we had in September. We have a little house in Ngumo West, and we give housing to these mothers, and we have a lot of more mothers too. So I invite you to please give these mothers, if you find a mother on a crisis in an antenatal care, you give these mothers our phone. That will be at the end of the presentation. About the maternal and fetal assessment, it's also important to prevent the gestational diabetes. The gestational diabetes, we have to prevent, we have to say to the mother that eat healthy, do exercise if she's overweight, and all of that. But also, there is a kind of secondary prevention because we can make a screening for mothers that have more risk, more likelihood rate to have it. In my country, in Chile, for all the mothers, they have the screening because, like in my country, we have a lot of prevalence of gestational diabetes. But here in Kenya, the people are more athletic, they do more sports or work more, and there is no so much obesity and overweight. So the screening is not for all the mothers. It's only for the mothers that have a risk factor. So which mothers can have the screening? The mothers with high body mass index, over 25. The mothers with previous gestational diabetes history in the previous pregnancy. The mothers that have glycosuria in the dipstick, because the dipstick is not only to check UTI, it also can help to check preeclampsia because of the proteinuria and to check gestational diabetes because of the glucosuria. Another risk factor is to have a previous large baby, over 4 kgs, or poor obstetric history, or family history of diabetes, or known intolerance glucose test, or this disease altered glucose altered in the blood in fasting, or also a grand multipara, that is more than 4 babies. So how we do the screen? The screen, we do it between the week 24 and 28, because in that week is the week of most insulin resistance index. Like in a normal pregnancy, that is the moment in the pregnancy where you have more insulin resistance. And how we do the test? We take OGTT, that is oral glucose tolerance test. You take the glucose in the blood in ayunas, that is fasting, without eating in the morning, and after that you take it 2 hours after, eating 75 grams of glucose. So if in fasting the exam is over 7, or after 2 hours the exam is over 7.8, you can refer this mother to the Diabetes Comprehensive Clinic, okay? Because these pregnancies are very high-risk pregnancies and need management by an obstetrician and a diabetologist or internist or diabetes educator, pediatrician, neonatologist. You need a lot of different professionals that can treat this pregnancy because have a lot of different risks. For example, macrosomy, that we can see here. And can you see the shoulders of this baby are very big? So we have risk also of shoulder retention, shoulder dystocia, perinatal asphyxia, a lot of different complications. So it's very important to refer these patients to manage them good. Another important thing about maternal and fetal assessment is the secondary prevention of HIV, syphilis, and tuberculosis. For HIV, we have the P24 test. For syphilis, the VDRL. And for tuberculosis, I don't know really what exam do you use, but I know that it's covered by Linda Mama, and it's all of these exams are for screening, and you take it in the first antenatal care visits. And what say the World Health Organization about the ultrasound? They recommend an early scan, that means a scan before 24 weeks of gestation, for all the pregnant women, because it's very important to have a correct diagnosis of the gestational age, and it helps with a lot of different things. Improve the detection of fetal anomalies, multiple pregnancies, reduce the induction of labor for post-term pregnancy, and improve woman's pregnancy experience. And in Kenya, we know that it's not for free. The Linda Mama insurance doesn't cover this, but it's important for all of us as healthcare providers to recommend this mother that is good if she can pay for an ultrasound. It's good that she pay. Maybe it's expensive, but she can afford it. So if a doctor recommends to her to have one and she only can pay one, it's preferable to choose the scan between the week 20 and 24, because this gives us a lot of information about gestational age, but also about the anatomic status of the fetus, about the number of fetus, about the placenta. So it's a very useful information. This is a presentation that I used in another classes to show the importance of an early scan, only to show you that when you have a scan early, like in 18 weeks, for example, in the case of Faith, we can diagnose after that intrauterine growth restriction or macrosomy. But if we have the scale, the ultrasound, late, like in 33 weeks or late, we won't be able to diagnose IUGR or macrosomy, and if we have that diseases, we will diagnose around gestational age. We will say that the fetus is 26 weeks when really is 33, but the fetus is with a disease. Or we will say that the fetus is with 40 weeks, but really the fetus is with macrosomy. So it's very important if we want to make like a routine control obstetric scan, it's very important to have it before the 23 weeks. Preventive measures. The preventive measures that the World Health Organization recommends is to check the blood group and resource in the first visit in order to categorize the mother if she will need or not need the anti-D immunoglobulin. If the mother is rhesus negative, we have to give this immunoglobulin. Why? To prevent the mother sensitization. If the mother is rhesus negative and the baby is rhesus positive during the delivery, the blood of the fetus will make the mother create antibodies against the rhesus. And in the next pregnancies, the antibodies that the mother creates against the rhesus will attack the fetus inside the womb and can make hemolysis and anemia for the fetus. So it can take a lot of problems for the fetus. So after the delivery, if the mother is rhesus negative, we take the fetus blood group. And if the fetus blood group is rhesus negative, there is no problem because the fetus is also negative, so the mother will never sensitize. But if the fetus is rhesus positive, we have to take, we have to give to the mother before the discharge the immunoglobulin. That is the anti-D monoclonal immunoglobulin. So that immunoglobulin prevent the development of antibodies from the mother against the next pregnancies. Sorry if I explain it bad. I know that my English is very bad, but I try to do it the best that I can. If you don't understand, of course, you can ask me and you can call me or send me a message. Tetanus toxoid vaccination. This is also recommended by the World Health Organization, and the government, the Linda Mama program, covered this. Okay, this is the schema. So who are the ones that need this protection? All the pregnant women. Here I miss a P. And when we have to give this? We have to give a schema of a lot of 5 doses of toxoid. The first dose is when the primigravida gets pregnant, on the first contact. On the first antenatal care visit, we can give it. Then we give the second tetanus toxoid dose after 4 weeks after the first one, or maybe later than that, but not before that. Okay, in the same pregnancy. Then the third dosage, we give it, but not in this pregnancy. We give it if the mother gets pregnant again. When the mother gets pregnant again, we give the third dosage, that is in the second pregnancy, before the 32 weeks. And the same in the 4 doses is the next pregnancy, that means the third pregnancy, before the 32 weeks. When the mother gets pregnant by a 4th time, we give the tetanus toxoid, the last dosage, and it means that the mother have the protection for life. So if she continue getting pregnant, we don't have to give it anymore. That is the tetanus toxoid. So which are the recommendations about malaria? We know that malaria is not prevalent in Nairobi, so it's not an endemic area, but there are a lot of different endemic areas in all Kenya, all around Kenya. So we need to know this because maybe we can be working in a very far away place where the malaria is a very important disease. So the World Health Organization prevents malaria, and they recommend for the preventing of malaria to have the screening of one MPS at the first visit of the antenatal care visits. Also to have prophylactic treatment. That means we give this treatment to all the pregnant women, okay? Not for the women that have a malaria, for all the pregnant women. Because we assume that a mother that is living in an endemic area, she can have malaria without symptoms. So we prefer to treat. And how we give this treatment? We give sulfadoxine, three pills of 500, that means 1,500 milligrams, and pyrimethamine, 25 milligrams. All of this, we give it one time during the second trimester, not before, and we give it one time. We wait 1 month, and we can give another time. The ideal treatment for prevention is 3 or more doses. So we have to give this 3 times or more, but not less than that. If we give less than that, the treatment is not complete, and the prevention is not as successful as it will be with 3 or more. Also, the Linda Mama program gives a mosquito net for the mothers that are pregnant. I forget to say that if the mother is allergic to sulfas, we need to forbid this treatment, and there are a lot of different treatments in the guide of the World Health Organization with hydroxychloroquine or chloroquine. Why it's important to know about malaria? Because the malaria during pregnancies have a lot of different outcomes, bad outcomes, and also the pregnancy, we know that the immunity of the mother is not as good as the immunity when you are not pregnant, so the malaria can attack strongly. So what can happen to a mother with the malaria that is pregnant? Maternal anemia, all of us know it, cerebral malaria, maternal mortality. Also, for the baby, increase the risk of preterm delivery and low birth weight, and the poor development of the baby and the behavior of the baby. So also increase the risk of a lot of different more things, but these are the most important. So that is the reason why it's very important to encourage this mother to take the treatment, the prophylactic treatment, and take it at least 3 doses, because if you take less than that, it's not so useful. So the last part of the World Health Organization recommendations is all the things that have to be with interventions for common physiological symptoms. During pregnancy, there are a lot of different symptoms that are common because of the pregnancy. And this mother can be scared with fear about this, because it can be maybe they will think that is a sign of a disease, of a complication of the pregnancy. So here the most important concept is to give education, to say to the mother that this is normal, in order to prevent the mother to take bad treatments or to go to a lot of doctors or to psychologically suffer about that. Okay, the important thing here is the education. And in addition to that, there are a lot of different things that this organization recommends to treat this, and we will talk a little about this. From nausea and vomiting, that is very common in pregnancy because of the hormones and all the systemic changes that we have. The WHO say to us that we can give ginger, chamomile, vitamin B6, or acupuncture. The chamomile, it have been working good with my patients, so you can try it, but you can give any one of those. And heartburn is very common also in pregnancy because the gravid uterus, the uterine size is very big, so increase the pressure in the abdomen, and the pressure inside the gastric cavity, it's big, so it increase the pyrosis and the heartburn. So what do you do here? You have to advise on the diet and lifestyles changes. So you have to say to the mothers that if she eats, to not go to the bed very fast. She waits only 2 hours, and then after that, she go to bed. Also, when she's sleeping, try to sleep like in a position not very horizontal. She can be a little with the head up, with more mattress. Or also, there are some drugs that you can give during the pregnancy. For example, all the antacids, most of them are recommended, are not forbidden in pregnancy. For example, Gaviscon, but omeprazole is forbidden, for example. Leg cramps, it's also very common in pregnancy, so here the most important thing is to say to the mother that is common. And some treatment with magnesium or calcium per oral can be useful if you put it together, because magnesium increase the fast movement in the bowel and the calcium increase the constipation. So if you give it together, it's an equilibrated combination. But also the leg cramps will go away together without doing anything. So you have to say to the mother that that is not an important thing, and she don't have anything more than that. There is no disease, there is no complication. Also very common in pregnancy is the low back and pelvic pain. For this, you have to recommend the mother to make regular exercise and to prevent the low back pain, low back pelvic pain. But sometimes the mother can do exercise, a lot of different things, physiotherapy and all of that, and the pain will continue. So you need to say to the patient that it's normal, that pain, and also the physical measures, for example, the local heating or like massage and topic diclofenac can help. Another common thing is the constipation. The constipation is common in pregnancy, and you can prevent it saying to the mother that drink a lot of water. Also, you can make a receipt of fiber or polyethylene glycol, that are drugs that doesn't absorb. So in pregnancy, it doesn't have affectation of the fetus. And to say to the mother that she have to eat a lot of different things with fiber, with fiber. For example, vegetables, non-cooked vegetables, and fruits, and all of that. For the varicose veins and edema, well, to say to the mother that sleep with the leg elevated, also water immersion, there are a lot of different things. But if she have a lot of edema, you have to rule out preeclampsia, because that is a symptom of preeclampsia. The non-pharmacological methods are the most chosen ones and the most safest ones. So also there are compression stockings, a lot of different things that you can use. But try to avoid all the drugs that you're not sure that are useful, because in pregnancy we try to avoid drugs. It's very important, that principle. Now I have this question for you. Can we give ibuprofen for the mothers for the pain? Or any other drug, any other painkiller, like for example, I don't know, to give a diclofenac, naproxen, or any other? Please put in pause the video and think a little about it. No, it is forbidden. And why it's forbidden? Because all the non-steroidal anti-inflammatories increase the risk of fetal demise, increase the risk of diminish of the amniotic fluid, also increase the risk of a lot of different complications and malformations for the fetus. So you cannot give it in any moment of the pregnancy, also increase the risk of premature closure of the arterius ductus. So you need to be aware and never give this, and also ask the mother sometimes, because they have pain and they take a painkiller, because they think that that is the thing that they always do when they were not pregnant, so they can take it. And you need to say to her, you cannot take ibuprofen, diclofenac, any of that. The only painkiller that you can take is paracetamol. The last part about prevention is the aspirin. This is a slide taken from another presentation, but it's about when you give aspirin, you can prevent the preeclampsia appearing. So if you give aspirin, low dose, 81 milligrams per day, from the week 12 until the delivery, until the week 36, you can prevent the development of preeclampsia. And which mothers are candidates for this treatment? Not all the mothers. Only the mothers of one high risk factor, or the mother with 2 or more moderate risk factor. Here in this table you have the risk factor, so I don't want to read it again, but it's only for you to know that it's a very important thing. And in the antenatal care visits, all the healthcare providers always forget, because it's a kind of a new rule, and these things are very new, 2018. So maybe the old people that work in the antenatal care don't know it, or they think it's not very important, but this can prevent preeclampsia, so it's very, very important. So the little golden potatoes of this class, sorry if I make you having a very boring time. But this topic is very important and it's not an emergency topic, so I don't see it very much. I don't work in the antenatal care, I only work in the hospital, in the place where the emergency occur. But this is to prevent the emergency, so I think it's the most important topic, and I think it's the topic that all of you are going to do in the future, working in clinics, in little clinics, in rural areas, so it's very important for you to know. The little golden potatoes is prevention is the key to success. So the prevention is an anticipation. You do the things before in order to avoid the disease to occur. The antenatal care must have 8 visits recommended by the World Health Organization. We know that it's difficult, and in places like the northeastern part of Kenya, I like really be proud if you can make 4 visits. But here in Nairobi, if you have time and you can recommend the mother, you have to say the mother that it's better to come 8 times to the visit. Because if you take the blood pressure 8 times, if you take the fundal height 8 times, it's better. You have a more near follow-up of the mother. And also, you have a more quantity of educations for the mother. So it's good in all the ways. It doesn't have a bad thing. The third point, the third little golden potato is that the WHO recommendations are based on evidence, so are things that have scientific investigation and are justified, so are our guide. But we know that we need to adapt this to the proper context of the country for our patients. We need to adapt this for the budget of the patient, because some patients cannot pay an ultrasound. But we need to say to the patient the importance of that. We need to say to the patient that if she had money, she have to pay it, because the information of that scan is very important and will prevent a lot of different complications that can be more expensive than an ultrasound. And the last one is that take care of the booklet, because the booklet is very useful, and I think all this presentation can be summarized in that booklet. The booklet have the information for all the prevention of all the disease, and it's very good. There is a lot of work under that book, so please use it. So now that we have seen all the topics that we proposed at the beginning of the class, I want to say you thank you. This is our last class. So thank you for all your company. Thank you for your study. I hope that you can study a lot for the exam, because you're on a strike. You continue on the strike. And I hope you can get, all of you, the certification. We're on the way to having the CPD point from the Kenya Medical and Dentist Board. So that is a good notice. But we don't have the definitive answer yet. And well, thank you very much, and I hope we can see it again if I return again to Kenya, or maybe we can continue with online classes from Chile. So thank you very much. I know that I'm not very good teacher because my English is not very good, and also because I don't study teaching yet. I'm a doctor very recently, and I don't have too much experience, but I think that I can share with you like a kind of knowledge that we know from Chile, from my country, that I study a lot in my country, but I don't practice. So I think you have the practice part, all the things, the procedures, you can do it, and you attend deliveries, and you do cesarean sections, but the theoretical part is the thing that maybe in this hospital is missing. So my main objective was to provide that information. Well, I hope that maybe in the future we can do better classes and we can improve. Any doubt you can say to me, you know. And here is the thing that I promised to you. That is the little booklet about the foundation where I work. And here, this number is the number that the woman have to call if she have any crisis during the pregnancy. You can recommend to her. They will be attended by Domitila, that is a mother that works with us, and she have 24 hours, 7 days a week. All the time she can answer the phone, and we can give support for this woman. So thank you for listening to me, and see you in a few years.